I think then that we should make a start, because I'm sure people will carry on joining. This session is recorded so that it can be shared with colleagues or watched again if you wish to. My name's Sarah Morgan. I'm the chair of the NCL Training Hub and the Camden Training Hub, and we're delighted to bring for you a series of long-term condition webinars. Today is our first on diabetes. We've got COPD and asthma in the pipeline, followed by hypertension and heart failure. And these ones are called Getting the Basics Right, so they really are a refresher for all of us, just to cover off some of those basics. And also, I think, to cover a bit how we work in these different times of remote working. Also to link in with some of the UCLP work that some of us may be aware of risk stratifying those at risk, and maybe prioritising who we're doing our long-term condition care planning with. So I'm delighted to have Arshna and Daniela to join us today. I'll let them introduce ourselves and let's make a start. We have said that we'll share the slides, and for those who are just joining us now, if you want to put your email address in the chat, they will be shared with you. And also, please do put any questions in the chat, because we want to make this an interactive session, and Arshna and Daniela will pick up some of those questions as we go through. Thanks.
Thank you very much for inviting us both to talk about diabetes. Arshna and I are both, it's our favourite subject, so we're very happy to talk all day long about diabetes. Just a brief sentence about who we are. I'm a jobbing GP, but I'm the lead at my practice for diabetes and have been for good on coming up to 20 years. And I'm also involved in training, and I'll let Arshna introduce herself.
So my name is Arshna Sangra, diabetes prescribing pharmacist. My background was community for a long time, but then I joined, trained in diabetes, and then joined Milway as a diabetes specialist pharmacist. And I also work 2 days a week in an outpatients clinic doing just diabetes. So diabetes is my passion, and I hope that today we'll be able to give you lots of information to help you guys deal with your patients living with diabetes as well.
So we've prepared some slides giving a sort of basic background, because I'm aware that on this webinar there are people from a lot of different clinical backgrounds. And I'm sure you have different levels of confidence dealing with diabetes. So we're going to just, go back to first principles. And we're going to look mainly, essentially from a primary care point of view. So it's the kind of patient that walks in through the door in primary care. Next slide, please. So at the end, we're also going to just talk about some risk stratification and how you might be able to apply this in your practice, so that you can have a non-GP allied healthcare professionals doing some diabetes long-term work. Next slide, please. This might at first look a little bit complicated. It's not, and it's really just to give you an overview about what's happening with diabetes. So we're going to look at, I'm going to just give an overview of what should normally happen. When we eat our food, we digest it, and all our food is eventually converted into glucose, because that is the fuel that the body needs to be distributed via the bloodstream to the muscles and the other organs in order for them to work. So we eat something, it gets digested into glucose, that glucose leaves the stomach and goes into the bloodstream. Once in the bloodstream, though, it needs some help to get into the organs and the muscles, and that help is insulin. And normally, we've got a normal functioning pancreas. The pancreas will detect that there's sugar in the bloodstream. It will release insulin, and that will help blood sugar get into the organs. Of course, in diabetes, this doesn't happen. And there are two things that might be wrong with the way insulin works. It could be deficient, so there's not enough insulin being produced. That's what we refer to as type 1 diabetes. What we see mainly in primary care is type 2, where actually the body might have higher than normal circulating levels of insulin, but it can't be used. There's resistance. So something is preventing the insulin working and getting that sugar into the body where it needs to go. And the body essentially thinks it's starving because there's all this fuel circulating, but there's a blockage in the system and the organs can't use it, and the body may think it's starving. And that's where the complications come for diabetes. And we'll talk a little bit about that later. But that's where some of the acute presentations come from, with metabolic imbalance, rapidly losing. What else did I want to say about that? The liver plays a very important part. And again, that might explain why sometimes when we ask people to blood sugar test, they get odd readings. But throughout the day, the liver is there to store a little bit of fuel so that it can release it again when we go into our natural fast at night. And that's the role of the liver. And that's important to understand because some of the medication we will prescribe will also work on that pathway. So can we have the next slide, please? This is just an overview of different types of diabetes. You may have heard that there's sort of 5 main types of diabetes, so just a very brief overview. Type 1 and type 2 are what people, I'm sure, are very familiar with. Type 1 and type 2 are completely different conditions. Type 1 diabetes is what's referred to as an autoimmune condition. It's when the body produces antibodies that destroy the insulin producing cells in the pancreas. It often presents very early in life, in childhood. The majority of these people will be looked after in secondary care. What we're going to see a lot of is the type 2. Type 2 is insulin resistant. So this is when I was saying there might actually be higher levels of insulin circulating in the body, but the muscles and the organs of the body can't use it. There are lots of reasons for this. It might be that there's excess sugar from diet, but it might be that people are very overweight, lacking exercise, and that changes insulin resistance as well. Type 1 and type 2 people often look very different. Their body habitus is different. Type 1 tend to be slim, they're not overweight. Type 2 tend to have central obesity and carry some excess weight. Gestational diabetes is important because we need to pick it up. So it is screened for as part of standard antenatal care. But we need to think about it because it does lead to complications. It leads to big babies. Those babies tend to have immature lungs at birth. From a primary care point of view, we are the ones that are going to be responsible for following up women who've had a diagnosis of gestational diabetes during their pregnancy. So it's important to think about a foolproof way of following these people up so that they're not missed. Some of those women will continue to require insulin after their pregnancy. And then we've got LADA and MODY. So LADA stands for latent autoimmune diabetes of adulthood. The best way to describe that is type 1 diabetes in adults. So this is an autoimmune condition. Think of this if the person in front of you doesn't look like you might expect them to look with insulin resistant. So they might present with weight loss and they may be slim. There is a way we can test for this now in primary care. It's very simple. They're called GAD antibodies, and I'm going to have to read what it stands for. And it's glutamic acid decarboxylase. It's on TQuest, and we can do a very simple test to try and diagnose people. Why is it important? Because they're the ones that will need insulin. MODY is the opposite of that, maturity onset diabetes of the young. So this is type 2 diabetes in young people. That's insulin resistance. It's not very common. In my practice, I think maybe 2 people in the last 20 years that I've picked up, but it does exist. And I'm just going to add another one there, steroid-induced diabetes. Think about your people on high-dose, long-term steroids for whatever underlying condition. Rheumatoid arthritis, picked up quite a few in my practice who are on long-term steroids. Might be people with asthma on long-term steroids, but it's worth thinking about those people and maybe testing for diabetes. Next slide, please. This is really just a slide to represent what I've already said, that the majority of people have insulin resistance. So it's all those people in the green and the purple and the sort of red, all of that. The severe autoimmune is really quite a small percentage of people in the yellow. So just to give you an idea of that, that's what we're dealing with. It's the insulin resistant, overweight, lifestyle type diabetes. Next slide, please. Next slide, thank you. I'm not going to go into this in detail because you can actually look this up anywhere. A very good resource is Diabetes UK, or the clinical knowledge summaries that are produced by NICE. All of that's there, but we are going to send the slides around so you can use it as a reference. I will just mention that the diagnostic features, the diagnostic levels for gestational diabetes are different. They're lower. And there's also a condition called impaired fasting glycemia, which may not be picked up by simply using an HbA1c. There may be a normal HbA1c, but a persistently raised fasting glycemia. Those are now classified as pre-diabetes. Next slide, please. Next slide, thank you. So I just wanted to talk a little bit about what we do as part of sort of 6-month annual reviews and why we do it. Because again, all of these things, you can look them up. There are hundreds of websites that will tell you what should be done, but it's understanding why we're doing it. And if we understand as clinicians why we're doing something, then we can explain it to the patient and it's not so random for them. They can engage in their treatment more and understand why these things need to be done. So just spend a little bit of time talking about that. Diabetes is complex, but it's complex because it's not just about sugar. Diabetes needs to be thought of as a cardiovascular disease. So I mentioned before that sugar moves from the digestive system into the bloodstream. It should only, when the body's working properly, it should only remain in the bloodstream a small amount of time at an increased level. If it does remain circulating in the bloodstream, it's damaging. Sugar is a toxin to blood vessels. We have blood vessels all over the body, from our head to our toes. Once we understand that it's a cardiovascular disease and that sugar damages blood vessels, it makes sense what we're doing. So, of course, weight is important, BMI. More importantly is waist circumference, because it's that central obesity that is the most harmful. So it's worth doing waist circumference or getting the patient to do it. And again, there are numbers, and I can give you those numbers, but they're easy to look up. So for women, there is increased risk. I'm going to do it in centimetres. There is increased risk if the waist is 80 centimetres. For men, it's 94 centimetres. Once that waist circumference for women goes above 88, it's very high risk. And for men, it's 102 centimetres. So waist circumference is much more important than weight on its own. HbA1c, of course, is used for monitoring. And then we move into the things that are to do with cardiovascular risk. So it's blood vessel health. So the following things are looking and monitoring blood vessel health. So of course cholesterol, because cholesterol is something else that may damage blood vessel health, including triglycerides. EGFR, that's looking at renal function. Again, blood vessels around the kidneys. Urine protein, urine ACR. Protein in the urine is a marker of mortality and morbidity. So they are our high risk patients. Blood pressure for the same reason, cardiovascular health. And then of course, for those people who are on medications that may cause an unstable or push the blood sugar down, they'll need to do their own capillary blood glucose levels. Next slide, please. Something else that we should be doing in clinic are the foot checks. In the diagram, you can see a 10-gram filament. So these filaments are designed to bend at 10 grams of pressure. So we can't exert more than 10 grams. We test feet, again, for exactly the same reason that I've just mentioned. Circulation in the feet is affected, both the large blood vessels and the small blood vessels, and the sensation is impaired when the small blood vessels are affected. We should be doing this every 6 months, and we need to do the filament test, and we need to do a visual check of feet. I can talk a little bit about the kind of things that we need to cover. So we're looking at skin health, we're looking at any breaks in the skin, discoloration, dry skin, hard skin, because if there's sometimes you get really quite shockingly thick areas of hard skin, and we don't know necessarily what's happening underneath that. It can fissure and cut, infection can get in. Toenails, I can see in the picture that this person has quite long toenails, which again can cut into the skin. There's impaired healing if there's impaired blood supply. Footwear is very important. And what we're recommending is a shoe that holds the foot by the ankle. I can't demonstrate it now, but if that's my foot, I don't want a slip-on that's going to squeeze around the toes. I want a shoe that's nice and wide at the toes, but the fastening is further up the foot to allow the toes some space. And again, sort of advice about walking barefoot. If you pick up somebody with that has impaired sensation, I also advise them to check inside their shoe before they put it on with their hands, just in case there's a thick seam, a little bit of cracking, a little bit of grit. They won't feel it with their feet if there's impaired sensation, and they might be walking around on a tiny little bit of grit, a couple of millimeters long. But if they do that all day, that is enough to cause a wound, and then we've got a big problem. The screening is something that's done by the retinal screening program. We just need to check that everybody has that done. Retinal screening is another marker. Retinopathy is another marker of morbidity and is telling you what's going on. Blood vessels again in the back of the eye. Next slide, please. So aims of treatment. I mean, fairly obvious, I think. We want to decrease mortality and morbidity. The issue with diabetes is that people have a lot of disability. They can be unwell for a long time before it eventually kills them. Sorry to sound so morbid, but that is the truth. So again, if you just have in mind what I said before, that it's a cardiovascular disease and everything we're doing is to try and improve and reduce the risks on the cardiovascular system. So you can see all those things written there. I'll just mention again about the micro and macrovascular complications. It's the microvascular complications around the kidneys that will increase mortality as important as controlling blood sugar. And way back there was a study called the UK PDS, which looked at all the individual components of what we do in the clinic, and blood pressure control came up as one of the most important things alongside sugar control. We've got on there maintain quality of life. I think on another slide we are going to talk about mental health, but it's a difficult condition to live with, diabetes. It's with you all the time. So I would urge people to understand what makes we talk about compliant and non-compliant patients. I would sort of urge people to think about why a patient might not be compliant and what they're finding difficult. Because if we understand that, it will help us with our management and our discussion. Next slide, please. This just reinforces that what we already know, I think. Type 2 diabetes is really what we're talking about, is a lifestyle condition. A lot of what I do in my clinics with the diabetes is actually talk about this, talk about diet, talk about food, talk about exercise, talk about what makes it difficult for them, understand how a person's life, you know, their responsibilities, their work, their family commitments, how it might impact and how it might make them difficult to follow this. But actually very little of what I do is about medication. Most of my conversations are about this. And I know Arshna is later going to share some really useful links. It's worth reading these yourself. You can learn so much, and it also gives you a vocabulary and a way to approach this and talk to patients about it. Next slide, please. So we're going to go and talk on about medication. I'm going to let Arshna do that. But just to remind you about emotional well-being, it is a hard condition to live with. You can never forget about it. Every time you eat, you get invited out to a party, somebody brings you a treat. You know, people always bring cake and biscuits for treats. Exercise, good weather, bad weather, taking your tablets, giving insulin, testing your sugars. You know, for people who have to do blood monitoring, it's really painful. It makes your fingers very, very sore. It's fiddly, it's time consuming. So just to remind us to get into the habit of asking about mood and how people are coping and whether there's any depression associated with their diabetes, and try and give them some support with that. So I'm going to hand over to Arshna, unless I can't see, don't know if there's anything in the chat for some, I don't know why I can't see it.
So
but,
there was a question on fructosamine and when fructosamine should be used instead, and I have posted an answer in there. But as a general rule, if your patient has hematological disorders, then HbA1c may not be accurate, and so you may want to use fructosamine as a measure. However, it's quite rare actually that we use fructosamine, and fructosamine is probably not as widely used as HbA1c. So if HbA1c is suitable, then we would say use it.
Oh, you've gone silent, Arshna.
Arshna, you are on mute now.
Sorry, can you hear me now?
Yes.
So there was a question about fructosamine. And I've posted an answer in there in the chat, basically just saying fructosamine should be used when HbA1c is unreliable if patients have hematological disorders. It's quite rare actually that we use fructosamine in general practice. Generally in hospital, we tend to use it much more because we see much more complex patients as such who have got hematological disorders. But in terms of conversion tables, Diabetes UK have a table online that you can Google and download, which gives you equivalent HbA1c numbers to what the fructosamine numbers are. Usually when you order a test, sometimes the lab, actually, if you expand the lab result, it sometimes gives you the equivalent HbA1c as well. But generally, we don't advise that you use that unless, of course, your patient does have hematological disorders. So that's just something to bear in mind. Could we have the next slide, please? So there are so many different guidelines that are available out there. There's obviously the NICE guidelines, which we use in the UK, the SIGN guidelines in Scotland, the EASD and the ADA guidelines. The NICE guidelines are about 4 to 5 years old. The EASD are probably the most current and stratify patients by their cardiovascular risk with treatment choice. So we tend to use those much more now than we do NICE. However, there are some technical updates to the NICE guidelines which came out over the last 2 years, so that's worth looking at as well. And of course, we are in England, and so technically, the NICE guidelines are probably the most current English guidelines. So the truth is, in practice, both Daniela and I probably use an amalgam of both of those, the EASD and the NICE, and in hospital we do the same. And the one thing that Daniela mentioned was about individualized targets and individualized care. That's got to be at the heart of your management of your patient. So, just because it says so on a guideline doesn't mean that is exactly what you must do. You must do what is right for your patient, bearing in mind what the guidelines say. So like Daniela said earlier, you've got to really think of your patient and then decide your treatment and management according to what's right for them. Next slide, please. So the gist of it generally is this, what's on this slide, and at the crux of it is very much diet and lifestyle. And that should really form conversations all throughout, as Daniela said. Once diagnosis is there, HbA1c is above 48. Usually we start metformin as our first line drug, and then you add in different drugs as per intensification once HbA1c is raised above 58. And you can have the first intensification, second intensification, third intensification. Usually at that stage, you're thinking insulin. Very rarely do we use 4 oral agents, however, it can be done. And of course, we use all of these in an adjunct to insulin as well, or injectable therapy as well, which I'll talk about a bit later on. And we'll send out the EASD guidelines as well afterwards if you've popped your email address in the chat bar. So you can actually look at those in a bit more detail. And they actually stratify intensification according to cardiovascular risk. So they recommend certain treatments according to that. So next slide, please. So this is just a pictorial account of the EASD guidelines, and they actually look at, as I said, risk stratifying according to cardiovascular risk. If the patient does have cardiovascular risk, really considering certain agents like an SGLT2 or a GLP-1, which has shown better benefits all around. If, of course, they don't have cardiovascular risk, then it's looking at other more conventional treatments as well. So we'll send these out in the after the chat, so you can actually look at that. You can't actually see it very clearly on this slide at all, so you can then pore over it at leisure. Next slide, please. So, being a pharmacist, medicines are my favorite thing, and so I've been tasked to talk about the medicine elements of diabetes. And actually, what I will say is that medicines form only part of your treatment plan. The bulk of your treatment plan must be around lifestyle changes. Diet, exercise, emotional well-being, all those are the pillars that really must underpin medicine, and medicine must come as an adjunct thereafter. And that sounds a bit strange saying it as a pharmacist, because we're trained to give out medicine willy-nilly. So, but really with diabetes, unless you actually control all these 3 elements, you're never going to get to the crux of the disease. So you've really got to take a holistic attitude. Now, metformin has been one of the oldest drugs used to treat diabetes. It's been around about 50 years that we've been using it now. It's very well known. We know its actions, we know its restrictions, we know its contraindications, and NICE recommends it as first-line therapy. It is fairly well tolerated by most diabetic patients. And really, the side effects are mostly around gastrointestinal side effects. And it works basically by countering insulin resistance, and it decreases hepatic glucose output as well. So it sort of sensitizes the body to insulin, as well as stopping the sugar factory in your liver from producing excess glucose when you do go through periods of emotional stress or the body is under stress itself. So fairly well known, works quite well. We start using it fairly early in the journey. The second drug that's been around a long time, second class, is sulfonylureas, which are slowly falling a little bit out of favor now. And nowadays, we tend not to use it as second-line therapy unless you're trying to treat very high sugar levels, steroid-induced diabetes, as Daniela talked about earlier, or it's a short-term sort of crutch to help bring sugar levels down before other things can be initiated. It causes weight gain. It has one of the side effects, and especially in the elderly, we try not to use this, and also in those with renal function decline, because it is quite potent in that sense. How does it work? It basically just flogs the pancreas to produce more insulin of your own, and essentially it causes long-term beta cell failure quicker, is what we're seeing over time, and therefore really we don't like using this as long-term therapy. However, it's been around a long time, and a lot of GPs are very used to prescribing it, so you still find lots and lots of patients who are started on this as second-line therapy. But not without risks. Of course, if you prescribe them, you've really got to think about driving regulations, about checking your capillary blood glucose. So even though they're relatively cheap to use, they do come with other problems attached to it, which we need to be mindful of. And again, as I said, if you're prescribing for the elderly, really consider falls risk, hypo risk, amongst other things, when you're using any kind of sulfonylurea. DPP4 inhibitors, they were the new players around 25 years ago. Very safe drug. People thought, yeah, great new drug, we can start prescribing pretty quickly. However, it only brings blood glucose levels down by between 5 and 11%, and it works by inhibiting an enzyme which in our gut, which basically stops your body or sends messages to the brain when we eat. So it's the incretin effect, which is what it works on. It increases prandial insulin secretion, but the problem is about 40% of people don't have this enzyme pathway. So you have 40% of people who are non-responders to DPP4. And one of the things that we say is once you start it, check the sugar levels at least within 6 months. And if they have not started to go down by more than 5 to 10 millimoles per mole, then stop it, because it's likely your patient may be a non-responder. They cost on average between 17 to 30 pounds, depending on which brand you use. So if you're, per month of treatment, if you're giving them a drug which is not working, it's really something that you must follow up on within 6 months of starting to actually stop it. So the new kids on the block, I say new kids, actually they're not anymore, is the SGLT2s, but they've had a lot of interest recently from nephrologists and cardiologists around use of these medicines, and they work basically in a very simplistic way by inhibiting the reuptake of glucose. So as soon as sugar levels reach a certain point, you just basically pee it out. Excess sugar comes out of the urine, and they're very effective as a consequence in bringing down blood glucose levels, but also in weight loss. And on average, within 6 months of starting this, you can see up to 4 kilograms or so of weight loss, which is roughly around 300 to 400 calories a day you can lose on this medication. However, it's not without its problems. Obviously, when you have sugar coming out in the urine, there's an increased chance of UTIs, there's an increased chance of balanitis, thrush for women, so genitourinary infections are much higher, and so it does need very careful counselling. Sick day rules are essential, and also counselling on the risk of euglycemic DKA, which has been shown with these medicines as well. So they do need quite a lot of counselling and, change in patient behaviours around genitourinary hygiene as well. but they are quite effective. If you start them at very high HbA1c, so HbA1c is above 90, you can get a lot of glucosuria and of course a lot of then side effects as well. So it's worth noting that sometimes people think, oh, we'll start them at very high HbA1cs, but they often are then very poorly tolerated. And if the patient's had a bad experience on them once, they will never go back to them. So it's really worth thinking about. They're used a lot nowadays with heart failure patients as well, because there's such strong evidence now that they can reduce heart failure admissions, and that they have other renal and cardiac protective effects. So there's a lot of evidence out there now, and they are very much nowadays seen as second-line therapy for people who are living with diabetes. And of course, the newest contender in the oral therapy is an oral GLP-1 agonist released by Novo Nordisk called Rybelsus, which is, up until now, we only had injectable GLP-1s, and only a few months ago they've launched Rybelsus, which is an oral GLP-1, which is taken once a day on an empty stomach, ideally 30 to 40 minutes prior to any food, with only 150 mils of water. So it's a very specific mechanism of bioavailability, and so it has very reasons or ways of it being taken. However, this has opened up a lot of options, especially at times when we're not seeing our patients as much with COVID, where you can then prescribe a GLP-1 without having to teach injectable treatments. So watch this space. It's not yet on the NCL formulary. So before you, and that's one of the questions that's just come up, can oral GLP-1 be prescribed in primary care? Not yet on the NCL formulary, but it has got a formulary sort of reading fairly soon, and medicines management will communicate with us as and when it can be given. It is being prescribed privately though, and a lot of our private endocrinologists who also work in secondary care within NCL have started to prescribe it. So you may well find patients who have been given this privately. But watch this space. It won't be long before we also in primary care under the NHS will be able to prescribe it. Next slide, please. So pioglitazone is another medication which has fallen out of favor recently. Well, I say recently, but over the last 5 to 7 years. But it also works basically by increasing or decreasing insulin resistance in the body. And nowadays we hardly use this medication at all. Its family member rosiglitazone was recalled many years ago amongst cardiac issues and a scare around that. So nowadays it's not used very rarely. However, you may have patients who are on this long term, have been on it for several years. And in those where it works, it does work quite well. Acarbose, again, a very old school medication, was used, a while ago to stop glucose ingestion from the gut, but it causes terrible wind, and a lot of patients prefer to be diabetic than to be farting all day long or burping all day long, so not tolerated very well, and nowadays we hardly ever use it. But you do see a lot of patients who have therapy started abroad, especially in the Middle East, who come or settle here, coming to you being on acarbose. But nowadays, its glucose lowering properties are few compared to all the other medicines that we have, so we tend not to use acarbose much. Repeglinide and ateglinide have their place and have been used more so in specialist settings to bring down sugar levels. They're very effective, but because they're so effective, they can cause a lot of hypos. Very short-acting in so must be taken with meals, and because that means basically having to take it twice, thrice, 4 times a day when you're eating. But again, the risk, especially amongst the elderly, because it can cause hypos and because it is so effective at bringing down the sugar levels short term, falls risks are high. Also, in some patients, there's a very hit and miss approach in that we can't accurately predict the effect that they'll have. So we don't use them very much in primary care nowadays. Also to be aware of are the fact that a lot of patients take a lot of herbal supplements around diabetes, especially in the Asian community. There's big hype around chlorella and about neem, about various other herbal preparations. So it's always important to ask patients, what else are you taking? Are you taking any herbal supplements? And patients often think because they're herbal, they don't interfere with my regular treatment, or I can take them in place of my regular treatment, which often is not the case. So really important that you ask your patients what are they taking in terms of herbal supplements. The other thing I've put on there are obviously cardiovascular medicines. So lots of medicines are prescribed in adjunct in diabetes. So you have ACE inhibitors, you have blood pressure regulating therapy, you have diuretics, you have all sorts of weird and wonderful medicines which are prescribed for the complications of diabetes, including things like gabapentin for neuropathy, etc. So, but all of these have an effect on the person, on your patient, and therefore it's really important to look at all of these things in context. There's one question on the chat about when would you choose EMPA versus CANA in terms of SGLT2. The truth of the matter is that both of them have very strong evidence for use. Canagliflozin has recently had its license adjusted to be used with microalbuminuria and at lower eGFRs. So canagliflozin can be, selectively used for proteinuria or microalbuminuria patients at lower eGFRs. But whether, if a patient has good eGFR, whether you use EMPA, DAPA, canagliflozin, it's really, at the doses of canagliflozin 100, DAPA 10, or EMPA 25, they have almost equivalent actions. Cana 300 has slightly more efficacious glucoseuria, but it's very marginal. So, I wouldn't say one is better than the other. It's very much a class effect. Next slide, please.
Arshna, there's just a question from Azza Hassan who's got their hands up if they want to come in.
Go ahead, Azza.
Hi, sorry about that. I just wanted to ask about the oral GLP-1 therapy that you discussed.
Go ahead.
Yes, you mentioned it's prescribed privately. If we were to receive, sort of a letter privately, for us to prescribe it, is it considered red at the moment, or
Yes,
can we, take over?
At the moment, it is considered red because it's not on the primary care formulary, so I wouldn't prescribe it. It is quite costly at about £78 for a month's supply. And of course, we don't know exactly its action. It is a black triangle medication as well. So, if you do have adverse effects, you are meant to actually report it as well. So in terms of primary care, especially at our practice, we had guidance from the medicines management team at NCL who have said if you receive conversion from a private to an NHS, do not do it because it's still not yet on formulary. And of course, you're taking on prescribing risk there as well. So, my advice and what we're doing at the surgery where we're at in primary care is not converting them. Really, we're just saying you're getting it privately. It's not on NHS formulary yet, therefore we can't do it.
Okay, thank you very much for that.
Okay, so just pressing on, I'm conscious of time and I want to give you guys some time also to ask questions as well. So injectable therapy, you have insulin, which can be a basal insulin or rapid acting insulin or a mixture of both. So, that's important to keep in mind, and that is specialist domain. So unless you have had specialist training, I would say always refer out, and also when you're changing doses, a lot of patients you may present, your patients will come back to primary care and say, look, I'm on this insulin, I'm having hyper, so I'm having this, so I'm having that. Or if you're changing doses, also be mindful that, because insulin is quite a potent agent, adjusting or changing doses is complex. It can precipitate, a cascade of events. So really do think about that as well. Next slide, please. And of course, other injectable therapies, up until now, we had the GLP-1 agonists, which were only injectable, now obviously available as oral. But weekly, you have exenatide, semaglutide, dulaglutide. Daily, you have exenatide, liraglutide, and lixisenatide. And a lot of the hype around GLP-1 therapy is the fact that, it is it is a medication which can bring down your sugar levels quite potently. It also helps with weight loss and is now being used in bariatric clinics as well to help support patients to lose weight. So there are some other uses of it. The newest agent that came on the market a while ago is semaglutide, which has shown greater efficacy than some of the other agents that are on the market. In terms of the devices to use them, all of these do need a teach session. So it's not something that you can just prescribe and hope your patient can get on with it. I would expect that if you do start these, you would actually then spend time to teach the patient how to do it. And of course, if you're not able to do that, then I would refer out to the outpatient units who can then actually take on that task. Often get asked which one is better, weekly, daily. The truth is it really depends on your patient. If device injection is difficult, then dulaglutide has a very easy device. And with that device, the needle is not visible. So for needle phobic patients, we tend to use dulaglutide, which is Trulicity. Semaglutide is more efficacious, we know that, but of course it is used in the same way as an insulin pen. As are some of the others, so that's to bear in mind. Exenatide weekly had quite a strange device initially, but that's been now used. Now that's been upgraded. There's a new device for Byetta, so it's a lot more patient-friendly to use now. But there's not one which is better than the other. They all have their place. For weight loss, the daily ones are better, but of course, if your patient's not going to use it daily, or if compliance is an issue, then it's a waste of time. It's better to go for a weekly one where you're going to achieve some effect, rather than to do a daily one where your patient's not going to use it. So it's really dependent on your patient more than anything. There's a question in the chat bar. Can I ask whether these are allowed on NHS for just weight loss alone for patients that are not diabetic? So in primary care, we would not, they're not licensed, so we wouldn't expect you to prescribe them. Saxenda is licensed for weight loss. However, it is not on the NCL formulary for weight loss in primary care. We do see patients in secondary care, especially in bariatric clinics, being prescribed them for when they're not diabetic, but supply is from the hospital. It's not expected that primary care will take them on. Take on prescribing risks. So it's usually prescribed in the hospital, followed up in the hospital for non-diabetic. So we wouldn't expect that you would see that or initiate that in primary care for weight loss. There's another question. Somebody put their hand up and then put it down. Mohammed? No, maybe not. Okay, fine. Next slide, please. COVID-19. So when COVID-19 came along, it really put a spanner in the works. And from March onwards, it was almost like primary care sort of went on hold, and long-term condition monitoring also went on hold. And with diabetes and COVID-19, it soon emerged. There was a lot of evidence that showed diabetes or patients living with diabetes were at some sort of additional risk when contracting COVID-19. The complications were a lot more. And the NHS around June published a paper by Vallabhji which looked at the additional risk of complications with patients living with diabetes. And that basically told us two things in a nutshell. If you have diabetes that is poorly controlled, i.e. HbA1c above 85, and you contracted COVID-19, there was a 1 in 10 chance of death and a 1 in 3 chance of you having all other complications related around, or cardiovascular complications related around COVID-19. So it soon became apparent that good diabetes control was necessary to reduce complications if you had exposure to COVID-19. The full paper is available freely on the government's website. So if you just Google, NHS diabetes COVID-19 Vallabhji paper, you can see all the findings on there. But the take-home message is, if you are a patient living with diabetes and your sugar is badly controlled, you are more at risk of death and complications with COVID-19, hospitalization complications. So, it's something to really bear in mind. And now more than ever, I think it's time to drive home the message that you've really got to stay on top of your diabetes as much as possible. Of course, there is post-COVID recovery support for diabetes, and a lot of the hospitals, Royal Free Hospital and all of them, have long COVID referrals now being accepted from community. So it's important to be aware of those, especially for your diabetic patients, because they can often present with these complications 6, 8, 10 weeks after COVID exposure. So it's really important to bear that in mind. Of course, we all started doing remote consultations, and they require different skills. One of the resources that we will actually send out is a guidance sent out by the PCDS, which is the Primary Care Diabetes Society, around how to maximize interaction at remote consultations for diabetes patients. So we'll send those out if you've put your email in the chat bar as well. So remember that as well. The flu jab and the pneumonia vaccine are key at this time of year. So with every patient living with diabetes, it's really important to plug this. And the double whammy is, you know, if you get flu and COVID at the same time, what are you going to do? So really, really important to make sure that you're plugging the flu jab as much as possible and the pneumonia vaccine as well as part of your care that you're offering your patients at the moment. Now, with COVID, with so many patients on a back foot behind with their reviews, UCLP obviously came up with a strategy to allow us to risk stratify patients, and that's one of the things that we want to talk about next. Sadat, could you please bring up the next slide?
While we're just getting the other slides up, it's the number of drugs available for diabetes. There's been a veritable explosion. It's quite overwhelming, even for somebody who has been, you know, doing primary care diabetes for a number of years. All I would say to you is don't be overwhelmed. Read a little bit about the really common ones that we use, for instance, metformin. Go away, read about it, understand how it works in the body, and then look at the patient in front of you and think, what does this patient need? Does this patient need help with blood sugar control? Does this patient need help with weight loss? Does this patient need help with cravings? And then find the drug that fits the need of the patient. And you, depending on what your role is, you may not be the one making that decision, but you can help whoever you are talking to for advice make that decision with you by saying, actually, this is what this patient needs. And that way, with every patient, you will learn a little bit more about the drugs. This is, you know, this is not something that we're going to be able to learn in one webinar. So thank you. We've got the UCL partner slides up. Before I go on, Sarah, are you going to be sharing these slides as well?
Very happy for them to be sent out as well, yes.
I wasn't going, so if we could go to the next slide. So this is, I quite like the content of these slides. It's a way of trying to risk stratify our patients, our diabetes patients, because as you've probably gathered, they're not all the same and they have different needs. And of course, we're doing much more virtual work now. It's not as scary as it might sound. We can do an awful lot virtually. A lot of it, however, does depend on the patient having a little bit of equipment themselves. So I'm encouraging everybody to buy their own blood pressure machine, and we can do really quite a lot remotely without a patient. So the next few slides are a way of risk stratifying our patients and then thinking about how allied health professionals can take on more responsibility in managing various aspects of diabetes care, and there is a lot of scope. Next slide, please. So this slide is self-explanatory. It's just sort of thinking, you know, high risk, medium risk, low risk, and what the main needs of each of those patients are. I think, you know, the low risk ones, it is going to be mainly lifestyle and reinforcing that. Next slide, please. So this goes into a bit more detail about what the different risk stratification is. I'm not going to talk about everything on this slide. When they're sent round, you can read them yourself. I did just want to highlight a couple of things to try and explain why it makes somebody high risk. So if you look at the red, I mean, obviously a high HbA1c, but there's also low GFR. So that patient, of course, is somebody that's probably already got vascular disease, most likely due to diabetes, because their GFR is low. And that's going to be complicated because a lot of the oral drugs that we use are metabolized by the kidneys. And if we look at the yellow, they've got, of course, there's high blood pressure, but also proteinuria or albuminuria. As I mentioned before, that's a marker of morbidity and mortality. So somebody, if you had two people, both with the same HbA1c, but one of those patients had proteinuria, that's your high risk patient. That's your patient who's more likely to die. That's the patient we really need to focus on. In a similar way, in the other column is erectile dysfunction and diabetic retinopathy. Erectile dysfunction is an early warning system. You need a healthy vascular system in order to have for a man to have an erection. If they're not getting erections, it's telling you their vascular system is already damaged. So that's why these various criteria make patients more high risk than others. The other things there are sort of self-explanatory, frailty and heart failure. So yes, so those are what I would say from this slide are the things that would make my antennae ping if I had this patient in front of me. Next slide, please. Again, this is just a different way of looking at the same thing. So on this slide, I wanted to sort of highlight DVLA guidance. Medico-legally, we have to do that. There's a very good website called Trend UK, which produces these excellent patient information leaflets. Read them so that you can have the conversation with the patient. There's been many a time when I've given the leaflet and said, go away and read it, and they haven't read it, because when they come back again and you mention it again, it's like we're having the conversation for the first time. So read the leaflet yourself and talk about the leaflet. So DVLA guidance is important, especially if we're prescribing medication that may cause hypos. The other thing I want to talk about on these slides we've talked about proteinuria, sick day rules. That's really important about use of insulin and the flozins as well in particular. But Arshna, I'm not going to go through that in detail because we haven't got enough time and it's complicated, but Arshna is going to send that round. So I think that's what I wanted to say on this slide. Next slide, please. So on this is some resources. Some are more useful than others. There was a question on the chat early on about whether we recommend high protein, low carb. I want to state that I'm not a dietitian, but I can tell you what I do in my practice. I use a website that's not listed here. It's called Choose My Plate. It's actually an American website, but I quite like it, and it's got lots of good visual graphics. And one of those is a plate with the proportions of the food groups. And I have very simple conversations because I'm a simple sort of person. And I talk about carbohydrate, that's the main culprit. And it might be that in future we have another one of these webinars talking about dietary advice. But in terms of protein, I use people's hand as a measure. and I say your portion of protein, whatever that may be, is the size of the palm of your hand. And I say start with that and pick a low fat, low carb protein. And the way I say that, because if you're vegetarian, a lot of your protein is going to come from pulses, and there's carbohydrate in that pulse. And then to measure the other parts, your carbohydrate in relation to your protein. And then your carb, if you're, that's the palm, the round bit, the palm of the hand, your carbohydrate portion is probably the whole of the hand, fingers included. So it's not a lot. And I actually don't go into much more detail than that. And I then ask them to sort of look at various food groups. So that's the website I use. But I know Arshna wanted to talk about some of the resources that she particularly, before I do that. So the purpose of these slides is just to say, whatever your role is, go away, think about what input you might have in a person's diabetes care. It may not be prescribing, but it might be that you're really good at fitness and you know how to motivate somebody. It might be that you're good at you like cooking and nutrition, and you'd like to read up a bit more about that, and you'd like to sort of get involved in that. There's lots of things that we can all do in our various roles. So maybe go away, look at those slides on risk stratification and think about where you would fit in, and talking to the people at your practices about maybe introducing this. But now I'm going to hand back to Arshna, because I know she's got some resources that she wanted to talk about and share with you.
So thanks for that, Daniela. I think conscious of time and the fact that a lot of our guests have other stuff to do, so just really want to bring it together to say that there is an awful lot of information out there, and the most important thing that you need to take away is the fact that your patient is an individual, and whatever impacts or changes or interventions you make must be obviously as a shared decision-making process with them, because if they're not going to do what you suggest, or they're not going to buy into what you're telling them to do, there's no point. So sometimes with diabetes, it's a slow road. You make small changes at each appointment before you actually get somewhere. So don't expect to make one change and fix their diabetes within 3 months. It just doesn't happen like that. It's a long process. The risk stratification documents that will come out to you in the slides obviously give you some idea on the kind of things to focus on and what to actually make sure that you've covered and not covered for what type of risk patient that you have. And of course, we would say to you, start with the highest risk first. We will send, Sadat will send out some resources which are very useful. So there are specific COVID sick day rules which have been published for diabetes patients, and we'll send those out to you. There's also guidance that has been published on remote consultations during COVID with patients living with diabetes, which we'll send out. Daniela mentioned the trend resources. Diabetes UK also have a helpline that you can give to patients for them to call up if they have questions about COVID, about their diabetes, about their medicines, and those are manned by diabetes specialist clinicians. So it's worthwhile knowing about that you can, if you haven't got the time to spend with your patient talking about it, just give them the number or signpost them to the Diabetes UK website. The number's on there, and they can then have that conversation with them. We'll also send out the EA guidelines, and that's really worth the read. If nothing, just a summary diagram will give you some really good ideas in terms of how to tailor your treatment according to the patient in front of you. So yeah, all those things we'll send out to the people that have put their email addresses on the chat bar. Diabetes is a huge topic, and it's one of those things which actually requires a lot of holistic thinking. So it's really worthwhile keeping that in mind, that you're not just treating a disease, you're treating a lifestyle, you're treating a patient's mental health, you're treating the whole shebang. So it's a slow process. So just want you guys to really keep that at the fore of your brain. And each opportunity, each contact you have, it's just another chance to actually make an impact, make a dent in this long journey. I'm just going to open up the floor to any questions, really. So please feel free to ask any questions if you have any. Danielle, I think we've stumped them all.
Oh, there's a few hands going up.
Okay, shall we take from Shobna first?
Oh, hello. I just wanted to ask you, Diabetes UK produced a very good booklet called Living with Diabetes 2 and 1. Do you use those booklets with your patients?
So we do use them at time of first diagnosis. So when a patient's very early on in their diagnosis, we do share that with them. And also at the structured education that's offered throughout NCL, those resources are given to the patient at that time as well. So if you've referred your patient for structured education, they will already have been given those resources throughout NCL on that program. But yeah, you're right, that those resources are available. And they're available in a PDF format as well now, so you could email them out to your patient as well. Daniela, do you want to say anything?
The only thing I was going to say, I mean, obviously everything's changed now with the pandemic, but it's worth making contact with your local, the Barnet, or actually I don't know where you are, but your local Diabetes UK group, because it's often run by very enthusiastic people, and they've been an enormous resource to Arshna and I when we've been planning some educational events for our patients within our practice. And there's just loads and loads of resources. So yes, we do use them, and we do have close links with our local Diabetes UK group. So yeah.
And the other thing we use is the information prescriptions, which are on EMIS as well, which you can print off and give. Those are also produced by Diabetes UK. So we use those quite a lot for patients. So that's worth using as well. And then embedded on System 1 on EMIS. So quite a lot of your PMRs will have them.
Just to let people know that it's free of charge. They just ring up the Diabetic UK and you can get like 50 per practice if you want to. But very useful. Thank you for that. Thank you.
Thanks.
Lana?
Hi, I've got kind of just two questions, if that's all right. One is about Flozins. You know, every time I want to start somebody on Flozins until you start explaining about the possibility of balanitis or vulvitis or UTIs, people actually put off. So although it sounds like good medication, is actually not preference for the patient. I mean, maybe depending how do you sell it, but if you actually follow the book, a lot of them are put off by that. So I don't know what other people are doing to encourage people to start on that, because not everybody likes to have infections.
I think in my practice, what we find is that it's exactly that, Lana, the way you sell it to the patient. And that's where it's really important to understand what's important to that patient at that time. So if weight loss is important, if bringing down their sugars is important, it's about using that as a hook and actually saying to them that these are the benefits of it and putting the benefits out there first, and then saying, however, it does require this much additional care from you. You will be, you do have to take more care with genitourinary hygiene. These are some of the things which can happen, and they more often happen in the first 2 to 3 weeks of starting treatment. I often prescribe clotrimazole or miconazole cream with the first prescribing, because your patient will get thrush, they may get balanitis, and if they know actually I've got something at hand, if it does start, I can start using that straight away, they're more keen and they're more able. But it's how you sell it, really, that's key.
I think that's probably the key. The other thing is, has anybody tried to do like we do now, Teams, but maybe Zoom meetings with patients, because it's probably more interactive and more interesting for people to see faces rather than to kind of tell them, speak to somebody on the phone. I mean, how does it work? I mean, we do use video consultation with patients, but not like hacker assistant calling 5 of them and telling them something. Has anybody tried that?
So we do this actively as part of the outpatients unit where I work at the hospital. And we have these kind of education sessions together with group consultation sessions as well that we run there. And we have up to 15 patients at a go. And what I will say is there is VGC training available, virtual group consultation training available at the moment, details of which went out on the GP bulletin as well for additional training. And yep, Sarah's put on there that there is is virtual group training coming into NCL, which has already started. So it's worthwhile going on one of these training sessions. It talks you through all the information governance and how you structure it, how you choose the patients, and what how you structure the sessions. It's really quite useful. But yeah, they work very well, and they are run. They can be run, predominantly by other healthcare clinicians. It doesn't have to be a GP or a specialist clinician running it. We run them at our surgery for pre-diabetics, and we have done for the last 2 years, and that's done by the healthcare assistants and practice nurses. So it is quite a powerful tool, and it can work very well. So yeah, that does happen, and it has been used for, show really good results as well.
Thank you.
Okay, there's a few quick questions in the chat. Lisa, you did have your hand up, but in the chat you've asked, is there any diabetes training for newly qualified nursing staff?
So I don't know of any as such. There is, however, the Cambridge course, which is available free online at the moment. This Cambridge Diabetes course, which is a series of e-learnings, which gives you a really good base on diabetes and how to manage diabetes in primary care. That's free at the moment because of the COVID situation. I don't know how much longer it will stay free, but that's worth thinking about. District nursing teams have some specialist training that's put on by the hospital hospital service for them, but I don't know of any others at the moment. There are, of course, lots of diploma courses. There's a Warwick course as well, if you want to train up more in managing diabetes, and that is available to you as well.
Can we include that Cambridge link in what goes out?
Yeah, can do. I'll put that on my list.
I'd certainly recommend the Warwick course. It was I did it quite a number of years ago. It's very good, but it's also quite a commitment. So you have to be you have to invest some time in it. There are no more hands up, but there was a question about the very low calorie diet program. So I'm not a dietitian. I don't know that much about the low calorie program. I believe it's an app and people sign up, and it's a 12-week program. We know that diabetes is reversible, and that if people lose weight, improve their diet, do more exercise, they can go into remission. Of course, depending on what stage you pick them up at. I suppose what I would say, is that a very low calorie diet is hard to maintain, and at some point they're going to have to go back to some form of normal eating, in inverted commas, and I think our role is to support them after they can be very motivated, very focused initially, but this is a condition that's going to be with them for the rest of their lives. So our role is how we motivate them and what other tools we can use to help keep the weight down and the sugars low more long term. And that's it. Arshna said that's really just about rapport, listening to your patient, not expecting too much too quickly. It may take several appointments for somebody to trust you, to put small little things into practice bit by bit. I think we need patience, and we need to be really genuinely interested in our patient and think about tailoring the advice we give to that person's lifestyle and their needs and the way they think. We don't all think the same way. So a bit of a wishy-washy answer, but it's the best I can give you, I'm afraid.
Also, just to the low-calorie diet program, which has been launched across NCL, in this Friday's or the Friday Gone's GP Bulletin, there is a link where you can sign up for the initial training. So that will give you more information on the pilot program, which is launched across NCL, and what patients are suitable. The one thing I will say is that the longer your patient has been living with diabetes, the harder it is to reverse. And so this program will really be looking at newly qualified or patients living with diabetes within 2 to 3 years of diagnosis. Of course, I don't know the full criteria, but if you want to know more for your practice, then definitely sign up to the training. The link was on the GP Bulletin as well. So that will give you more information on the low-calorie diet program. The other things you can do is read up about the direct study, because that's exactly what it's been based on. So, just to bear that in mind. There was one more question about canagliflozin and the amputation risk and whether there's any additional evidence on that. So the latest follow-up credence studies that were done after have actually shown that this risk is not shared. So they feel that perhaps that risk was highlighted because the kind of patients were more prone to it as well. The subsequent other SGLT2 evidence or studies done thereafter have not shown that much of an increased risk with amputation. So it's something to bear in mind.
Final question then about the 5-1 diet. What are your thoughts on that?
So the 5-2 diet,
5-2
I think is what you're thinking of. Yeah. So that was Michael Mosley is a GP that's done extensive research in diabetes, and he came up with this concept of 5-2, where you have 2 very frugal days, 2 very low calorie days, less than 800 calories, or fasting, and 5 days of normal eating. Now, fasting or intermittent fasting has shown benefit with diabetes and has shown benefit in trying to reduce weight and reverse diabetes. However, it is not for everyone. So it's not like a blanket, okay, do this and you'll get better. It doesn't work like that. People who have renal disease or are taking blood pressure medications, it's really important that you actually counsel them very carefully before they embark on these kind of intermittent fasting or low calorie diets. There are a couple of books which patients can look at, or even you as clinicians should be aware of, because patients who know about 5-2 know about these books. And one is the 8-week blood sugar diet by Michael Mosley. The other one is called the Fast 800 diet, which is based around intermittent fasting and 5-2. It can work, has really good evidence around it, but it's not for everyone.
Thank you both. And Catherine's posted something in the chat about something that she's running for healthcare professionals as well around low carb information that's in there. Okay. Thank you, Daniela and Ashna. That was fantastic. I feel like I learned so much, and it's also made me think I need to do a lot more learning as well. I think everyone's found that really useful. So thanks so much for giving us your time today. And on behalf of everyone, I'd just like to thank you both for preparing that and taking us through that. Thanks everyone for joining us. I hope that has been useful and sort of inspired you to go off and do a bit more with your diabetic patients. Thank you very much. You're getting lots of lovely comments in the chat group, both of you.
Thank you, everybody.
Thank you, everyone.
Thank you for inviting us. Bye.
Thank you. Thank you.